So the COVID global pandemic has affected the entire globe. And I think every day we hear about it being a rapidly evolving situation, and the word unprecedented often comes up. Now that we are more than 6 months into the pandemic, we're starting to ask ourselves now, what just happened? And in reality, we don't have a lot of answers yet about what's happened to breast reconstruction and breast cancer. And the data is still coming in, and we're still processing early data right now. But obviously the impact of the COVID pandemic on breast cancer and breast reconstruction will echo for many years. And it's important to have conversations now that can prepare us to rectify and mitigate the unintended consequences of the response to the pandemic. The racial and ethnic disparities in breast cancer are well described. Black and minority women are diagnosed with more advanced breast cancer and typically have and often have worse histology and higher mortality. The reason for this seems to be multifactorial. Genetics and tumor biology play a role, but also very importantly are the social determinants of care, things like insurance, education, access to healthcare, transportation, and finance. Racial and ethnic disparities in breast reconstruction are also well described. In this study from 2018, this group from Harvard looked at the racial and ethnic disparities in breast reconstruction using NISQIP data from 2005 to 2014. In this slide on the left columns, the rainbow of colors represent the different years, going from oldest to in 2005 to the most recent data in 2014 is the green on the right. And I say over time, you can see that the percentage of women who use breast reconstruction has gone up over time to a point, their most recent data from 2014 shows almost 60% of women choose breast reconstruction. When the group breaks these trends down by ethnic groups, we see that white women overall have enjoyed more breast reconstruction than Black, Asian, and Native American women. All groups have increased over time, but Black, Asian, Native Americans haven't increased as much as white women. The conclusions we can draw from this are that disparities in breast reconstruction are improving, but are persistent. The index of disparity, which is a well-described statistic looking at differences in ethnic groups compared to an average rate, shows that the index of disparity overall has improved from 55 to 22, which is great, but it also shows that improving access doesn't always improve receipt of care, that there is still a 22% index of disparity as of 2014. And I think it's also important to consider the 4-year data delay. The study was published in 2018, and their most recent data was 4 years old at the time in 2014. So there's a 4-year delay between when the data was registered and when it was published. The COVID global pandemic has limited hospital resources due to a surge in critically ill, highly contagious patients, and it's affected healthcare delivery worldwide. In March of 2020, CMS made the important decision to cease elective surgery and procedures, again, to limit, to preserve resources for this surge in critically ill, highly contagious patients. The American College of Surgery, the SSO, the ASBS made the important decision to delay non-essential breast surgery and to maximize neoadjuvant endocrine therapy, again, to preserve healthcare resources for the sickest people suffering from COVID. And shortly after this, the American Society for Plastic Surgery made a recommendation to delay autologous breast reconstruction due to its resource-heavy needs and to use implant-based reconstruction mindfully. And these recommendations were followed, we believe, with varying degrees of mindfulness. It raised many controversies in breast reconstruction. One of the most important questions that it raised was, is breast reconstruction elective? And I think that the community, the plastic surgery community, has been fairly divided on this issue. One study showed that as we're making the decisions about how elective breast reconstruction is, brought to light the fact that women who have delayed breast reconstruction enjoy similar patient-reported outcomes as do women with immediate breast reconstruction. And immediate breast reconstruction, they remind us, does have higher complications than delayed breast reconstruction, simple mastectomy. And for this reason, priority has been given to delayed breast reconstruction in many centers rather than immediate breast reconstruction. Other centers suggested using more of a shared decision process with a discussion with patients and families about the realities of having limited healthcare resources during the pandemic. And then the questions further evolved: is free flap reconstruction really inappropriate? At first, we felt that that huge need for resources to perform free flap breast reconstruction would take away from resources needed for taking care of the sickest COVID patients. However, recent backlash has started to arise that perhaps with implant-based reconstruction, there are going to be more readmissions and infections, and maybe implant-based reconstruction is actually more resource heavy than we thought it was, and maybe it's not more resource heavy in the long run than autologous reconstruction. And one group described the limitations on free flap reconstruction as possibly unfairly restrictive. These are all important considerations and important decisions to make. And there's no clear answer as to what the right answer is for breast reconstruction during the acute phase of the COVID pandemic. It's not all doom and gloom. The COVID pandemic has forced us to, in plastic surgery, to become more efficient in delivering breast reconstruction. And several innovations in this efficiency in delivery have been published. One group from Mass General talked about using virtual visits, an aggressive ERAS protocol, and with their small group, they found no readmissions when they used same-day surgery and these virtual visits and ERAS to minimize person-to-person contact, but still accomplish the goal of breast reconstruction. Another group also published on their use, their aggressive use of ERAS and pre-PEC reconstruction, which has shown to have less, women who use pre-PEC reconstruction have less pain. And their group also showed no readmissions during this, the acute phase of the COVID pandemic. And then a group out of Italy showed good use of direct-to-implant reconstruction using microtextured implants, which are available in Europe, and I'm not aware of them being available in the US yet, but found success with delivering breast reconstruction using direct to implants and not tissue expanders. In terms of disparities in care for breast reconstruction during COVID, there's no data that has been published yet about this. Again, we're a little more than 6 months into the pandemic, and I'm sure data is being collected, but it's not widely available yet. But I think we can anticipate factors causing pre-COVID disparities to be exacerbated by the pandemic, specifically socioeconomic factors like finances, transportation, family needs, and access to technology. Looking forward, I think it's extremely important to anticipate the problem. I expect that Black and minority women will likely receive less breast reconstruction in the acute post-COVID period for several reasons, especially the higher burden of COVID pathology in this population. And I anticipate that we'll see a disproportionate economic burden in this population. It's critically important for us to start data analysis now. If we don't recognize this problem for 4 years, if it takes us 4 years to define the problem, we'll be too far behind. It's important for us to start examining our data now. As we examine our data now, both on institution, local, regional, and national levels, it's important for us to examine specific local barriers to care for these populations. Every system has their own barriers, and every system knows how to examine those barriers. And we've already worked with those barriers, against these barriers, to improve access before the pandemic. And it's important for us to amplify our current outreach techniques and improve the outreach to extend them to these populations so that they don't suffer undue lack of reconstruction. And it's important to start conversations about this now, to acknowledge the problem now, start the conversations, and start planning for the future so we can mitigate the lack of reconstruction that these populations will likely face. And this works when we all work together, and I know we can do this together. Thank you again for inviting me for this talk. I look forward to doing it again. Thanks.